So as you said, chronic heart failure is becoming increasingly common in the United States and also in the world. And over the last several years, there's been development of new medications to help with this disorder. In the last, little over 5 years ago, a class of medications called angiotensin receptor neprilysin inhibitors, or ARNIs, sacubitril combination drugs, sacubitril valsartan showed significant benefit in heart failure with reduced ejection fraction. And then most recently, a class of medications called SGLT2 inhibitors have also shown benefit. Both of these classes of medicines were then studied in heart failure with preserved ejection fraction, which is also quite common. And unfortunately, historically, there's never been a drug that has shown benefit in that patient population. So first, sacubitril valsartan was studied in that patient group, and then lately SGLT2 inhibitors have been studied. Both have shown promise in heart failure with preserved ejection fraction, mainly with reducing heart failure hospitalizations. Unfortunately, both class of medications did not show benefit in terms of survival. So whereas we have several medications that have shown survival with heart failure with reduced ejection fraction, we've not seen the same with heart failure with preserved ejection fraction. And I think the community now is, even though these medications have been around for now several years, and with SGLT2 inhibitors coming on in the last couple years, there's unfortunately still the problem that many patients are not started on these medications. So during ACC, we've seen many investigators have cataloged this problem to show that those patients who live in impoverished areas, or those that have living in socially disadvantaged areas of the country, unfortunately don't receive the same care as those that are living in more affluent areas. And also, encouraging, many investigators have tried to take it upon themselves to see what they can do about this. So there was a group in New York, which a lot of clinics now use electronic health records. So this group looked at alerts that physicians would receive on the computer to encourage them to start medications. And they found in their program that they were able to achieve significant greater use of guideline-directed therapy, looking at one class of medications after a period of 6 months. And so, I think anything that we can do as a community to try to widen the use of these medications in heart failure will lead to better outcomes.
Thank you.
Yeah. I'm just trying to think if there's anything else in terms of the other. There's always in heart failure, we're always looking at newer technologies, newer devices. One of the technologies that a couple of years ago showed promise in heart failure was transcatheter end-to-end repair of the mitral valve. So historically, mitral valve disease, which is seen in heart failure, can only be treated with surgery. But the technology now exists that you can, in many cases, repair a leaking tricuspid valve with catheters, so the patient does not have to have open heart surgery. So a few years ago, there was a study called COAPT, which showed benefit of this technology in patients with heart failure and a leaking mitral valve or mitral regurgitation. And they looked at patients and they followed patients for 2 years. So earlier at ACC, they showed that this benefit at 2 years was seen out to 5 years. So that patients who got this repair of the mitral valve out to 5 years had better outcomes. Now, the one caveat of the study, though, was that at 5 years, a lot of patients who had received this repair either were still admitted to the hospital or they unfortunately passed away. Less patients died, though, that received the therapy, but still that even out to 5 years, outcomes were not ideal. So this really just shows to highlight that we still have to do a much better job of trying to treat these patients and making sure they're on the appropriate therapies for heart failure. So cardiac contractility modulation is basically a form. It's a device that patients with heart failure have implanted. It's like a pacemaker, but it's not. It's different. But it basically applies electrical signals to the heart during what's called the absolute refractory period. And this is felt to stimulate contractility to make the heart work better. So there was a study published many years ago called HFpEF, which in a small group of patients showed promise. So those of us in heart failure, if we have patients that, despite medications, they're still symptomatic, this is a technology that has promise. In my institution, we do use this in a select group of patients. One of the idea being, though, in the study, they did not show that people lived longer, but they did show that patients felt better, so their quality of life was improved. Now, the downside of the technology is it is a device, so it requires a patient to have, it's the size of a pacemaker implanted in them, but it's not open heart surgery. It's done, patients don't have to stay, multiple days in the hospital to have the device implanted. But the study was a smaller study, so it did not show that people lived longer. But I think the promise of this technology may be with heart failure with preserved ejection fraction, because as I said earlier, we don't have a lot of therapies for this patient group. So there is a trial called Aim Higher, which is currently starting enrollment. We actually at our institution are going to be a center for that study, so we don't have any data yet. But my hope is that a couple years from now that we will show that in patients with heart failure with preserved ejection fraction that this therapy may have some promise. So that will remain to be seen in the years to come. Currently in the guidelines for heart failure with preserved ejection fraction, the two classes of medication that show, well, there are three classes of medicine that have shown some promise. One is mineral corticoid receptor antagonists, or MRAs, which is spironolactone. The second class is ARNI, which is sacubitril valsartan, or Entresto, is it commercially known in the United States. And the last class is SGLT2 inhibitors, empagliflozin and dapagliflozin. But all of them have mainly shown potential benefit in preventing hospitalization, which, as we know, is very important for our patients. But the strength of evidence is not as great as we see for those medicines with heart failure with reduced ejection fraction. So there is benefit, but unfortunately, we still are struggling with finding the one drug that we can tell a patient, if you take this drug, you're going to live longer, or your heart failure will go, be reversed. Unfortunately, our therapies nowadays are mainly to treat symptoms and to prevent people from being hospitalized. So they are in the guidelines, particularly the newer guidelines will have SGLT2 inhibitors in heart failure with preserved ejection fraction, but we're still waiting for the one drug that will make patients live longer who have HFpEF. So, when we look at newer therapies, I think I mentioned one earlier, I would really like to see if something like cardiac contractility modulation, CCM therapy, may help. Earlier today, a group in Mayo published their trial, which was called Rapid HF, which was the idea that patients with HFpEF may benefit from atrial pacing. Unfortunately, they did not see any benefit. It was a small study, 30 patients in each arm, but it was unfortunately a negative study. So it did not show any benefit. It was published also today in JAMA. So we're still looking for that one therapy device or medication that will show benefit in that patient group.